Hey Mama, welcome to Parently Live. Today we are so excited that you're here because we are talking about VBAC. And I know lots of women are in this, they put themselves into this category of being a woman that had a C-section before and you feel like maybe you failed as a mom, that you didn't get that vaginal delivery that you wanted. And we are here to help you get this next dream delivery that you want. So we're talking to Dr. Boyd about VBAC and everything that he knows and all of the things that you need to know to consider if you're a candidate for VBAC or not. So tell us a little bit, just kind of an overview about VBAC, and then we will get into it. But I do want to say before we get into it, click the link below and download your free Power Pregnancy Workbook. It'll be super resourceful for you. And now let's get into VBAC.
Okay. It's important to understand if you are even a candidate for VBAC, you have to look at the statistics in the United States. 1 out of 3 women has a cesarean section. And in that group then, you have to subdivide yourselves on what type of incision you had both on your, mainly on your uterus. And we'll talk about the skin incision and the uterine incision here in a minute. But vaginal birth after cesarean section should be considered for every single woman that's had a cesarean section, with some understanding that there are women that fall into the category for VBAC candidates and there are women that are not. And you have to define yourself whether you fall into one category or another. I've got some definitions. We've got a dry erase board here today that we're going to give you some definitions and what to specifically look for when you talk to your healthcare provider. So
before we even go into that, can we talk a little bit about so you said VBAC is a vaginal birth after C-section.
Right.
So, women that have never even considered this before need to think, okay, why couldn't I have a vaginal delivery after a C-section? So you were pregnant, you went to the hospital with your first baby, and for some reason the scale tipped and they had to have a C-section for maybe a medical reason, just different reasons, and now they're pregnant again. Why wouldn't they be able to deliver vaginally after C-section? What could happen maybe that would say, no, you need to go for C-section again?
Okay, so let's pull up our dry erase board here and we can answer those questions. Now, we want to make sure there's no glaring of the light, so we're in good shape here. So first of all, you have to understand what this terminology means. Vaginal birth after cesarean section. Now that is the completed process. VBAC candidates, and several years ago we actually turned to this term because this is a woman that has been successful in delivering vaginally. So vaginal birth after cesarean section. But the question that you have to ask yourself as a patient is, am I a candidate for trial of labor after cesarean section, TOLAC? And that really is what we as healthcare providers look at to see if you're a candidate. Now, the type of skin incision is irrelevant on whether you're a TOLAC or a VBAC candidate. So these two drawings demonstrate the most common skin incisions that doctors make when they perform a cesarean section. This is the most common one. This is called a fan and steel incision or a bikini incision. So this is your abdomen, and your lower abdomen down near your pubic bone. Doctors make a skin incision that goes transverse, sideways. That skin incision is the most common type of skin incision for cesarean sections in the United States. This type of skin incision used to be done 20 years ago and before that. This is called a vertical incision, and rarely do vertical incisions occur in the United States. Usually women that have had a vertical incision, it's because they've had an emergency type of cesarean section and your doctor thought that they could get into your abdomen faster if they make a vertical incision. But the skin incision, again, that's most common is this low transverse or fan and steel incision. Now, the most important distinction on whether you're a TOLAC or a VBAC candidate is the type of uterine incision that you had in your prior cesarean section. This is the most common type of uterine incision. This is called a low transverse cesarean section incision, LTCS, low transverse, because it occurs low in your uterine body. That is the most common type. And that patient, if that's you, you're a candidate for a TOLAC or a VBAC. The second candidate that can be successful in achieving a TOLAC or a VBAC is a patient that's had a low vertical incision on their uterus. Again, why would a doctor make a low vertical incision? If your baby was born really, really early in the prior pregnancy, around 25 weeks, sometimes women don't have a very developed lower uterine segment. So where we make the incision with this low transverse incision, the lower uterine segment is not well developed, and so a doctor may elect to do a low vertical incision on the uterus. Again, we're talking about on the uterus. And again, this patient is a candidate to undergo a trial of labor. Now, sometimes doctors have to do a classical cesarean section. Again, sometimes this low vertical incision, a severely premature baby, has to be converted to a classical to get the baby out. And in that scenario, the uterine incision goes into the body, even into the top of the uterus. This patient is not a candidate for a vaginal birth after cesarean section. The most important aspect of this is if you have a doctor that's done your prior cesarean section, he has your records so he can look at your operative report. But if you had your cesarean section in California and now you live in Florida, well, you want to make sure that you bring those records to your doctor for your subsequent pregnancy so that they can make a determined decision whether you are or are not a vaginal birth candidate.
So you've shown the different incisions that are either yes or no for a woman. What is the reason that some of the incisions will not work for a VBAC? What could happen?
So I demonstrated that classical incision. That patient, if they were to undergo a trial of labor, has an increased risk for uterine rupture in the next pregnancy. So if you've had a classical incision and you elect to undergo a VBAC, and again, this would not be something that your doctor would agree to. This would be something that you would be doing on your own. You have an increased risk for uterine rupture. Now, it's important to understand that all women, anytime they have an incision on their uterus, whether it's a low transverse incision, a low vertical incision, you do have a small risk for uterine rupture. And that is why every VBAC candidate or every TOLAC needs to deliver in a hospital where they have a doctor on site. So the new wave of medicine in obstetrics is they have what's called a laborist. And that is a doctor that's on the labor floor 24/7. Usually hospitals that do 1,000 deliveries or more per year have a laborist on the floor. So you as a TOLAC candidate are undergoing labor, a doctor's right down the hall so that if your uterus ruptures, he can quickly take you to the operating room. If your hospital does not have an in-house doctor, a laborist, then they may say, we do not do VBACs in our hospital. Or they may say, if you do a VBAC, you, the doctor, has to be in-house. And that it's very cumbersome and laborsome for doctors. If they're trying to be in the office, it's very difficult to be in the hospital. So many smaller hospitals have elected not to do VBACs. And so you as a patient then have to say, well, I'll just undergo a repeat cesarean section, or I'm going to try to go to a bigger hospital where I can undergo TOLAC or VBAC.
Yeah, so very important to talk to your physician, your healthcare provider, whether he's comfortable with VBAC, talking to the hospital, knowing what their success rates are, if they have nurses that are comfortable with laboring with them. So you said uterine rupture. What exactly? So they have an incision from their previous C-section and they are having contractions and there's pressure on the uterus. So what is uterine rupture exactly? What happens?
So let's bring this dry board back up. So if you look at we'll use any of these incisions here, but we'll use this one specifically. So if you've got a baby's head that's pushing here, So the uterus is contracting, and as your pregnancy advances, this part of your uterus, that's the cervix, starts to thin out. And as it thins out, it also thins out this uterine incision. And so with contractions that are active and pressure from the baby's head, sometimes that incision splits open. So the incision has scar tissue. Just like if you've been cut on your body, you've got a scar. Scars are weaker than normal tissue. They don't stretch as well. So a normal tissue stretches. This is a muscle. The uterus is a muscle. It's a smooth muscle, and it will stretch. But if you have an incision on your uterus in any of this capacity, that uterine incision doesn't stretch as well. And when it doesn't stretch as well, if there's pressure on it, sometimes it can split open. So this would split open in any of these situations potentially, and that would potentially cause massive bleeding. And it's an emergency. It's something that has to be addressed right now, or the baby can die or the mother can die. Now again, with this type of incision, this low transverse incision, the risk for uterine rupture is only about 1.5%. Some studies show it's as high as 3%, but most authorities around the United States agree that it's about 1.5%. Now, I always flip this around and say to you as a patient, if you had a 98.5% chance of winning the lottery, you'd go buy a lottery ticket. All of us would be there. The problem with looking at it this way, though, is if you lose the lottery, even at 98.5%, you don't win the lottery, nothing lost. You've lost some money. The 1.5% risk for uterine rupture, knowing that you can die or your baby can die or you both can die, oftentimes will prevent women from making that decision. So that is why it's so important that you talk to your doctor and make sure that he is comfortable, the hospital is comfortable, you're comfortable, and your family's comfortable before you make this decision.
Yeah, so you talked about the incision. So depending on your type of incision can make you a candidate for VBAC. What about how many times they've had a C-section? So that scar tissue, each time, they go for a C-section, so say they've had 1 C-section, 2 C-sections, is there a number where their doctor will say, okay, you can't VBAC because you've had so many C-sections?
So that question obviously is very important because of the number of cesarean sections that are done in the United States. So there's no specific answer on this for the number. And every doctor, every patient, every hospital is going to be a little bit different on what they feel comfortable with. Most doctors that are board certified in the United States feel comfortable if they have a hospital that has the adequate facilities. Most doctors in the United States will allow VBACs for 1 prior cesarean section. There's a smaller number of doctors, and I'm in this smaller number, that will allow you to have 2 cesarean sections, and I feel comfortable managing that patient for TOLAC. Understanding again that she understands the risks and the hospital has the correct facilities to do an emergency cesarean section, and that's the key word, emergency cesarean section right now. So 1 doctor or 1 cesarean section, most doctors feel comfortable with allowing you VBAC. 2, smaller number, rarely, and I don't know of any myself, that if you had 3 cesarean sections, I don't know any doctors I know personally that would allow that. Now, it's also important to understand when you're considering VBAC, what your cesarean section was, what the reason for it was last pregnancy. Mm-hmm. So let me give you an example. So let's assume that your first pregnancy, your baby ends up breech. Mm-hmm. That means the butt down or the feet down. And the baby doesn't flip and you get to 40 weeks and you undergo a cesarean section. That patient is a great VBAC candidate, assuming, again, that your doctor did a low transverse incision on the uterus. Sometimes breaches are a little bit difficult to get out, and sometimes doctors have to tee the incision. And again, that would be a candidate. That patient would not be a candidate moving forward. However, most breaches are delivered with a low transverse incision. They would be a great VBAC candidate. Let's assume, though, you as a patient progressed to 7 centimeters and remained at 7 centimeters for hours and hours and hours, and finally your doctor said, you're not going to move forward, we're going to proceed with cesarean section. Or you got to complete, and you push and push and push, and you were unable to deliver your baby vaginally. Both of those patients have a higher failure rate with VBAC. So again, we want to stratify or quantify how many women are going to be successful in delivering babies vaginally after cesarean section. And the studies show that you have about a 70% chance of delivering vaginally, looking at all studies, but you have a higher failure rate if you're one of those candidates that has cesarean section because you failed to dilate or you were unable to push your baby out through the vagina in a typical fashion. However, I would never say to you as a patient, you're not a good candidate for TOLAC or VBAC because you had a failed labor last time. I would say to you, you still have probably a 50% chance of success moving forward vaginally. I can't give you an exact statistic. It's less than the 70%, but I still would offer you a trial of labor. And the reason is very clear. Cesarean sections have risks. You have risk for infection, you have risk for bleeding, and each subsequent cesarean section that you have a higher risk for having problems in the next C-section. Now, if you know you're going to have 2 babies and that's it, probably not a lot of risk with cesarean sections. But if you're going to have 3 or 4 or 5 babies, every cesarean section beyond that second one, you have a higher risk for bleeding and infection.
Okay, yeah. So it's very important then to sit down and talk to your provider and make sense of the story that happened. Why did you have a C-section? What went wrong? What was my incision like? Was my C-section anything to do with me, or was it just the position of the baby? So that's very important to know that birth story to make sense of, can you be a candidate for a TOLAC VBAC?
Yes.
So even just the mental, the mindset of this next pregnancy, that your first baby, if you had a C-section, that had its own story, and that doesn't mean that you are going to not be able to TOLAC or VBAC in this pregnancy. So very important to just kind of come together with yourself, talk to your provider, know the story, know your situation, and know if you're a candidate, and just move forward with this pregnancy saying, I can do this. I can TOLAC or VBAC if you are a candidate, and be confident in that. Relax those hormones for, labor. So
I'll mention a couple other things here. So one of the things that patients really struggle with is their story of what happened to them with their prior vaginal delivery or prior cesarean section. And it's very important that after you're said and done with whatever happened. So we'll give you a couple examples. So let's assume you had a long trial of labor and you were unsuccessful at delivering vaginally and you ended up with a cesarean section. You're exhausted, you had some increased bleeding, you spent a few extra days in the hospital, and then it's all over and you go back to see your doctor typically in a week and then again in another week. It's very important to solidify in your mind, from a historical standpoint, what exactly happened and why I ended up in the position that I did. And why that's important, whether you had the same doctor next pregnancy or another doctor next pregnancy, it's important to be able to describe what happened in detail. And again, we're going to have the operative report, but it's important for you as a patient to be able to accept what happened and then move forward with a plan. So next pregnancy, you can go back and say, this is what happened, A, B, C, D, E, etc. Now, as you move into this next pregnancy, or whether you're in this pregnancy, it's important early to make the decision on whether you think you want to be a TOLAC VBAC candidate. The reason I say that is so many things happen late in pregnancy. You're seeing the doctor more frequently, you're at increased risk for going into labor, and if you don't have a defined plan for what you're going to do, then you end up in a situation where you're not happy again with the outcome. And so again, it's the journey, it's the plan, but you don't want to make that at the last minute. So as you come into your pregnancy, that's something you want to talk to your doctor about immediately. Hey, I'm 8 weeks pregnant and I think I want a VBAC. Can we have at least a little bit of discussion? Now, many doctors will defer that until later in pregnancy, but again, this is your body. You have the right to ask those questions and make a plan. And each visit that you see your doctor, ask more questions. Am I a VBAC candidate? Let's talk about that. What's my risk? And then as you get to the end of your pregnancy, you can make the appropriate decision. The other thing I wanted to say is this. Many doctors in the past did not feel comfortable inducing you if you have a prior uterine incision. And many doctors still do not feel comfortable inducing you if you have a prior uterine incision. However, we have so much more information on VBACs and the risk for uterine rupture, and inducing your labor is safe and is acceptable if you've had a prior uterine incision. Now, your doctor may not feel comfortable with doing an induction of labor, but it is safe. And again, if you have these discussions with your doctor and your doctor is going a different way than where you want to go, you have the right to move doctors. You do not have to stay with that doctor just because you started with that doctor. At the end of the day, you want to feel comfortable with whatever decision you make. You don't want to be angry at that doctor because he doesn't feel comfortable. He has a right to not feel comfortable if he doesn't want to induce. But that doesn't necessarily mean that that is your plan. So if you guys aren't hitting it off and aren't agreeing on things, assuming that you're not doing something crazy, then I think I would encourage you to find a new physician that you will feel comfortable with late in pregnancy.
Yeah, absolutely. So that's it for our live stream on VBAC. We've covered if you are a candidate or not. So talk to your doctor, know your incision history on your uterus, know how many C-sections you've had, and know the position of the baby. What was the reason for the C-section, etc. So, and just have peace of mind about it, that this is a new pregnancy, it's a new baby, it's a new situation.
It is. And again, even though the past is super important in defining what we're going to do in this pregnancy. You just cannot, history is important for all of us, but from a historical narrative in determining what's best for you, we have to know your history. Yes. And again, VBAC only is even considered because of your history. And so if you don't know your history, there's no way we can identify what's best for you today.
Yeah. Yep. So that's all for today. Thanks for watching, everyone.
Thanks, guys. Have a good day.